am thrilled to be your MC today. With that, let's go ahead and get started by having the rest of our presenters introduce themselves. I will pass it off to Addie Van Zwol.
Thanks, Harper. So hi everyone, I'm Addie Van Swell. I'm a director here at the School-Based Health Alliance. A lot of my work focuses on addressing food insecurities in schools, as well as anything and everything related to mental health. While I pass it along to Sarah, I'm wondering if we can, thank you, Harper, launch the poll to get an idea of who you are and where you're coming from. So Sarah, do you want to introduce yourself?
Sure. Thanks, Addie. Hi, everybody. I'm Sarah Mills. I'm a senior manager on the health systems team at Share Strength. And I'm really happy to be here and been working with school-based health centers and their work to address food insecurity for the last couple of years. So yeah, excited to be here. Rainy?
Everyone hear me? Good afternoon, everyone. I'm Reem Ali, Executive Director of the Ohio School-Based Health Alliance. I'm excited to share our learnings on the network here today.
Hi, I'm Rachel Schilling, Program Manager of the Ohio School-Based Health Alliance.
And I'm Rebecca Goslin. I'm the Director of Clinical Initiatives with Youth Healthcare Alliance in Colorado.
Thank you so much, everyone. And I did put a fun question in the chat because I love to know who's here. So if you want to go ahead and say your name, your organization, maybe anything else you want to share with the group here today, and your favorite Thanksgiving dish, we would love to know. And before we get started, I just wanted to run through our agenda. Today, we're going to talk a little bit about the No Kid Hungry and School-Based Health Alliance partnership, a little bit about addressing food insecurities in school-based health centers, some more information and background about our state learning networks and partnership with Ohio and Colorado. And then we'll have our lovely state representatives share more about what they learned and what they hope to learn as they continue to do this work. And then we will move into kind of a summary and wrap up. So with that, I will pass it over to, I believe, Addie or Sarah.
Think it's both of us.
Perfect.
Hi again. So the School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. Since 1995, we've really been kind of the national voice advocating for school-based health centers and school-based health center services. And we really believe that all children and adolescents deserve to thrive. In a lot of ways that we are able to do that is through providing support to them in schools. So I'll pass it on over to Sarah.
Hi. So Share Strength is a national anti-hunger nonprofit. Many of you may be more familiar with the campaign No Kid Hungry that we created. It's really in place to ensure that kids are getting access to the healthy foods that they need in order to thrive. And so our campaign really focuses on advocacy efforts at the state and federal level to ensure that policies are in place and food programs are in place that can support kids and families. And we also work with local organizations through grant making and technical assistance to help support their work on the ground to ensure that no kid is hungry. So we started our partnership with the School-Based Health Alliance in 2021 and really, saw an opportunity with school-based health centers to be a partner in this work with addressing food insecurity. We know that school-based health centers are a trusted resource in their communities, and we really wanted to explore the ways that we could work together to make sure that kids got access to the foods that they need.
So with this work, we launched a national learning network of school-based health centers representing 12 states in 2022. From that, we created our toolkit, which Harper will so graciously put in the chat for you. But if you haven't taken a look at our toolkit, please do so. There's tons of information, lots of resources stemming from all of the work that our school-based health centers were doing across the country. And then last year, which we're going to talk more about today, is our work with the Ohio School-Based Health Alliance as well as Youth Healthcare Alliance, our two state affiliates who launched their own individual learning networks. And so they were launching their own learning networks. And then we also continued to support our 10 of our original school-based health centers from our original cohort. Next slide. All right. So this year, we're super excited to continue our work. So we will continue to work with Ohio and Colorado with the idea of wanting to expand our reach to other school-based health centers. We're going to focus a little bit of our work on evaluation and sustainability. We're also super excited to launch a national survey to learn more about what school-based health centers are doing across the country about food security. More details are certainly to come soon. But we have an idea of, that school-based health centers are doing some work in this area. We just don't have a very good understanding of that. So we're really hoping that by launching this national survey, that we will find out much more about all of the work that's being done. And then we're also hosting a webinar series. So we actually just had a webinar last week on bridging health and nutrition, food assistance strategies for school-based health centers. So this really looked at SNAP benefits and how to help families get enrolled. If you are interested in that webinar, it has been posted on our website. So you're able to go back and review it if you were not able to be present. The next two webinars are coming up in January and March. So we have one on kind of the continuum of food access programs. So we'll talk through kind of really easy, low time, low effort into very high effort and high comprehensive food access programs. So we're really looking forward to that. And then our third webinar will really focus on the intersection of mental health and food.
Okay, so our presenters are going to talk a lot more about what they did in each of their states and how they did it, and some of the impacts of their work. But just to kind of set the context of the goals of this project and the goals of the work in each of the states over the last year, one of the major goals was integrating food access strategies, a lot of the things that we had included in the toolkit and things that we had learned from the initial cohort, understanding how some of those strategies could be replicated in the school-based health centers in Ohio and Colorado. And one of the things that we heard a lot in our initial cohort was that folks wanted more of a network of support locally. And so the reasoning behind kind of bringing in the state affiliates for this second cohort was to figure out the best ways that they could provide that support to school-based health centers in their state, and sort of identify local resources or local processes that could be replicated across their local communities. And then, once those kind of local promising practices were identified, to be able to spread that across their network in their state. And part of what we wanted to do today was also to share the learnings across the two states as well. We think that a lot of exciting work was happening. We got the privilege of learning and hearing about it all along the way. And so really wanted to have the opportunity for, folks in Ohio to hear about what was happening in Colorado and vice versa. And then one of the final kind of goals of this work was really to learn more about how we could incorporate youth voice across the work that we're doing with food access in school-based health centers. So Harper's going to talk a little bit about some of the things that we did with that. But just briefly, there were a lot of successes. We're going to hear more about specific things in Ohio and Colorado. But across all of our work with school-based health centers to date, over 13,000 youth have been reached with food access resources through school-based health centers, which is amazing. You all have incorporated food insecurity screening, identified families who could be supported with SNAP or WIC application assistance, connected families to those benefits programs, and then also established a whole host of other food programs like food pantries, food boxes, produce prescription, cooking and nutrition education. It's been really, really amazing to see how the work has continued to grow. So we're excited to see what happens next and to hear from Reem and Rachel and Rebecca about all of the exciting things that happened this year that we're hoping will continue to grow.
Righty, before I pass the torch off, I did just want to lift up a little bit of the work that our sites and our states did with youth across the country. So we had youth involved at interventions at the site level through pantry operations and developing materials. This kind of included using groups that already existed, like a youth advisory council or committee, or a student council, but then also engaging students who were either maybe using the pantry or often seen in their school-based health center. So using kind of two different modalities to get students involved. We also had a youth advisory council do a field trip to a local farm to learn more about seasonal produce and kind of what happens when the food is grown and how it gets to the grocery store, to the pantry, and to the table. The Ohio School-Based Health Alliance had a state-level youth volunteer, which I think was a really great learning experience for everyone involved. Kind of the first time you do youth work one-on-one. It's just a great way to learn about kind of how you can grow that. We also saw some of the things that sites learned and the states learned from having youth involved in this work was really a reduced stigma and an increase in the use of on-site resources. So we heard kind of some of the quotes were like students saying, "Oh, what's that backpack? How can I get a backpack too?" Like, "Oh, those kids are going there. What does that mean? How can I also be a part of that program?" And then kind of across the spectrum here, we saw that every site was really interested in how to get youth involved. And that was kind of a goal for the work going forward, which was great. It's not on here, but I did also want to shout out the group in Ohio that brought students to our Be the Change youth training program, and they presented about the work they were doing on site to other students around the country to kind of spread the word about how your school-based health center can do food access work. And so that was really powerful too, to see students connecting with one another over the interventions that were happening. So yeah, if anyone has questions about that, feel free to pop them in the chat, but great work, everyone. And I will pass it off, I believe, to Reem.
Thanks, Harper. It was indeed a learning across the board when we had a youth intern. It was a really great experience for us, and we hope to really continue that work as we move forward. So a little bit about the Ohio School-Based Health Alliance first. And okay, great. So we are a statewide nonprofit organization that was really created to advance and support the sustainability and expansion of school-based healthcare in our state. We were actually founded back in 2002 and had a long period of really regionalized focus, and then relaunched with a much more statewide presence in 2021. And we've served as the designated state affiliate of the School-Based Health Alliance since 2010. You see here both our vision and our mission. And our organization's vision is predicated on ensuring that students in Ohio achieve optimal health and education outcomes. And our mission is to improve access to comprehensive integrated health services through school-based healthcare to improve outcomes for students, their families, and communities. A lot of the work of our school-based health centers touch on not only students, but again, they're the broader families and communities, and we see that through our food access and innovation work that we'll be talking about. And then we focus our work across these 3 categories to strengthen Ohio's school-based healthcare infrastructure and support our school-based healthcare partners statewide. The first area of focus includes our learning network around food access and food insecurity, and you'll be learning more about that. But really, this work has touched on all 3 of our areas of focus. With that, I'm going to hand the reins over to my colleague, Rachel Schilling.
Thanks, Rim. So our Food Access Innovation and Learning Network focused on the goals you see here. So first, just integrating food access interventions into health center services and workflows. Ultimately, we wanted to see improved food security for youth and their families and an increased connection to preventative care offered by the school-based health centers. And then more broadly, we wanted to just gain a greater understanding of how models for integrating nutrition assistance into school-based health centers can work, and then how they can be supported at the state level. And while we hope that we achieved all of these throughout the learning network, we do have measurable improvement in goals 1 and 4. Next slide, please. So stepping back a little bit, it's really important in Ohio particularly that we do work like this, because we know that if gaps in food insecurity were eliminated, then almost 37,000 children living in families experiencing economic disadvantage would not experience food insecurity. And on the next slide, we know that in 2022, over 500,000, or about 20% of Ohio children experience food insecurity, and that's 1 in 5, which is really high. And an estimated 31% of these children were likely ineligible for nutrition programs. So moving on to what this project looked like for us and in Ohio, we had 4 components that made up our work. The first is food insecurity screenings that are SBHC grantees implemented, or if they were already doing it, strengthening it. And then making referrals and connections to nutrition and food access programs when there were positive screenings. So that was, I'll get more into this later, but that was SNAP, WIC, Medicaid, and then more local resources as well, as made sense. And then a core piece of this project was data collection and evaluation of the work. And then just working toward building partnerships, particularly with community organizations, and working toward sustainability. So this work can continue even after the learning network is ended. And and whoever's changing slides is doing a great job. So here's the timeline. This was over a year. We just wrapped in September of this year. But in September of last year, we had launched the Learning Network. We had our orientation, and then in October, we really wanted to see that screening and referral process take off and be launched, as well as other interventions that were continued through August. And then in August and September, we did wrap up, we did final reports. We really focused on sustainability. So all of the sites in our in our learning network had the same core set of interventions. So the first was a universal food insecurity screening. They did have different screeners, and I'll cover that on the next, or in a couple slides, I think. But they were all doing universal screening, and then doing resource follow-up or referral, and then follow-up, which was a little complicated. And I'll get more into that later. That was the goal, and then ultimately strengthen and leverage community partnerships. And in addition to those, screening tools is the next slide. So most of our sites use the Hunger Vital Sign in one way or another, either as part of a larger screener or on its own. Some were using the RAPS or Prepare, and we did have one grantee that was using an in-house social determinants of health screener that included food access questions. So in addition to those core sets of activities, so screening, referral, all of our sites identified some unique interventions they wanted to work toward to address gaps in their community. And those look different depending on what needs they identified. So some of our sites focused on food distribution, largely to fill that gap maybe between being identified as experiencing food insecurity and getting connected to other sorts of resources, like SNAP or WIC. So that could be a food pantry or food closet that was established on site somewhere or near the school. Sometimes this was just having snacks in the school-based health center available, power packs. So like there would be like a food pack that the student could take home right then, or maybe over the weekend. Food delivery was something that was pursued by a few of our sites. And then something that I think is cool is cooking and nutrition classes. So pursuing partnerships that can provide these cooking classes, focusing on food you might get, like shelf-stable food that you might get from a food pantry or closet. We had a few youth advisory councils that were engaged in food security related projects, and then some other various things like community lunch and learns. Here are our grantees. On the left, we had 7, and then on the right, you can see where all those sites are. We had 12 sites that were participating. And we had a variety of SPHC sponsors, which I think is cool because then we could see some of the different ways the work might happen from different sponsor types. We had FQHCs, children's hospitals, and large hospital or health systems that were involved. And yeah, next slide. And then in addition, 2 of our grantees were part of that original cohort. So they had different sites. They were expanding to additional sites. It wasn't the same sites as in the original cohort, but it was really nice having their expertise and experience as part of the learning network. We met monthly, and I think this was really helpful for us and our grantees. Each meeting, we had some topic that we were focused on. Sometimes we had an external speaker come in, an expert in whatever we were talking about. Sometimes it was more of a working meeting, like working on sustainability plans. But every meeting, we did a site check-in. So each of our grantees shared their challenges and successes from the previous month. We shared resources, both coming from us, or sometimes the grantee shared resources with each other that they had found or that found useful. And then there were a lot of connections made. So again, between grantees, but also there were connections made. Maybe there were a few times where a grantee was like, I'm having this problem, and another one had a solution for them. They had a partnership that they'd established and they were able to share and make that connection. So that was really cool to see. And in addition to that, we had 2 statewide partners that we engaged in this, and they came to most, if not every, meeting that we had with the Learning Network. You can see those 2 partners here. The first is Children's Defense Fund, which currently oversees hunger-free schools, an initiative that ensures all students in Ohio have access to school meals. And then the Ohio Association of Food Banks, and they were instrumental in connecting our grantee sites to local food banks and community resources. They both also presented. The Ohio Association of Food Banks presented on food insecurity screenings and practices to our sites, and that was early on, and that was really useful to have. And then they both helped us stay connected to the state food access policy conversation around like school meals, as an example, and then Medicaid reimbursement for food resources. So it was also super helpful just having them there to be able to answer questions that were more at like the state level, the policy landscape, and just make sure we all knew what was happening or plugged into that conversation. These are some of the topics we covered. There were definitely more than this, but just generally, we talked about food access policy, like I mentioned. We were always talking about screening and referral, what was working, what wasn't working, challenges that our grantees are running into, and of course, potential solutions, ways to engage families and youth. We were also always talking about metric collection and documentation, just learning as the project went on, the best way to do that. And sometimes we had to make adjustments. how to establish and maintain partnerships, and then again, developing a sustainability plan. So how to make sure that this work continues. So like I mentioned, we're very focused on evaluation. I'm not just saying that because that's my main role. We always want to make sure that we're learning alongside our grantee sites, and this helps us do that. We approached evaluation in two ways. First was just evaluating the program and the interventions, and I'll talk more about that in a minute, but we had metrics that we used to capture the impact, and I'll share some of that data too. And then process evaluation. So this is more qualitative data, and we were just documenting lessons learned, or our grantees rather were documenting lessons learned, the processes they established, how things were going generally. And the goal of this was to identify best practices. We got data monthly from our grantees, particularly that quantitative data. We had a core set of metrics that everyone reported on, and then also some customized metrics to capture those more unique interventions I talked about, like maybe the number of power packs distributed in a month. And the core metrics were the number of visits to an SBHC, the number of screenings, the number of positive screenings, and then the various referrals that were made. And this was all youth specific. The next slide. I think, screenshots. So I used Excel for this, which there's pros and cons. A little heavier on the cons, I think, but it did work out. It did go well for this project. So you can see we have the metric name, definition, and we developed these definitions by working with our partners at SBHA and No Kid Hungry. We worked with our sites, and we had some back and forth there where they told us what they thought they could report on, what made sense. We had a place for notes and then fields for the actual data entry. And then on the next slide, we also had a tab where they could just take notes for their own brains to help them remember how things were going. So the goal of this was when we did process surveys, they could refer back and remember, a few months ago how things were going and how things had changed since then. This is some of that quantitative data. You can see month 1. So the first month that screening was kind of starting in red, and then month 9 in gold. This project did go through 12 months, but that the last 2 months were over the summer. Some of our sites were closed. Some kind of like pared down operations didn't have as high of a patient volume. So I chose just to stop it at 9 because that's when everyone was still screening. And you can see that there's a measurable increase at most sites. Some had a decrease, but that's just the nature of SBHC operations. Some months are better than others. Maybe something weird happened that month, and they didn't get all the screening done like they did the previous month. But yeah, you can see that generally there's an increase in screening. And then I have some more data here. So this shows the impact across the whole project. And just something to note, if there's other data nerds, is that while we ask for unduplicated youth each month, month to month, there might be a patient repeated, like if they had another visit to the SBHC. So there are going to be repeats in here, duplicated patients counted. But regardless, there were over 11,000 patients or visits throughout the project. And at just under half of these visits, patients were screened. We did push for universal screening every child, every visit, but sometimes there's a patient coming in weekly or monthly, and maybe they didn't want to take the screener every time. And then of those patients, about 10% were identified to be experiencing food insecurity. Of those patients, there were just over 2,000 referrals made to SNAP, WIC, and or Medicaid, so those federal programs. And then about the same number of referrals made to other forms of assistance, like those local resources. And then process evaluation, we had 3 surveys throughout the course of the project. Yeah, okay. So this is some of that qualitative data, some of the data we got from those surveys. These are some challenges faced by our sites. One of the biggest across both screening and referral is just lack of capacity. So not enough time, not enough staff. Maybe the EHR didn't capture data the way they wanted it to. And then capacity challenges weren't limited to the SVHCs. Some of our sites found that potential community partners didn't have the capacity to meet the needs of the site and the patient population. And that extended to a few different types of organizations. So, for example, one grantee found that patients' families weren't using the food access resources they were referred to, not because of stigma, but because the location was inconvenient or hours were too limited and they couldn't make it outside of work hours. And then another challenge and potential opportunity for organizations to fill is that our grantees found that most families that were identified to be experiencing food insecurity were already enrolled and participating in WIC or SNAP. Then our SVHCs felt like they couldn't offer a solution or offer any additional resources. So that's definitely something that we could help with, that we did help with throughout the course of the project, just identifying additional resources and things they could provide. But that was a problem. Maybe not a problem, like it's good that they were already enrolled, but a challenge that was encountered. And these are some of the key lessons learned by our grantees. It's important for our sites or SVHCs in general to be linked in and connected to their broader healthcare system. So some of our sites found that their larger system was doing work that they could be connected back with for this, and they weren't connected to that work previously. And then also it was important to prioritize documentation and follow-up when designing workflows. So making sure that there's a place in that workflow where you're documenting the outcome of screening, that you're documenting when the referral was made, who the referral was made to, but then also making sure there's that follow-up in place in a formalized way. Not just, someone should call at some point and see if they need help applying to that resource, but making sure that it's more formal. There's a dedicated staff person. Community health workers are great for this, for example. And then also it's important to prioritize community partnerships and interventions. Oh yeah, sorry, Harper. And then engage youth whenever possible. Youth were super useful for our sites that were working with them in addressing stigma. They were present at food distribution events, for example, brought in other peers to help, and were just champions of the work and really making sure their peers were comfortable and just didn't feel that stigma and accessing resources. Now the next slide, yeah. So here are some key lessons learned by us, the state affiliate, and the conveners of the network, was just how helpful it was leveraging state partners to provide resources, education, and really that policy piece too. A big lesson learned for me was automating and simplifying that data collection process for sites. That's super useful. And then part of that is just balancing like logistical ease, so making it easy on everyone involved, but also making sure that interventions were effective and everything was reported accurately. And it was really nice just having that monthly forum for mutual learning and support among all the partners. Okay, I feel like I've been talking for days. So I just wanted to close my part of the presentation by sharing our social media and newsletter if you want to stay connected, see what happens with this work and everything else we're doing. And I think that's it. And I'm now going to pass it off to Rebecca.
Thank you. It is always really insightful to see how this looks across states. So I'm going to speak to the work that Youth Healthcare Alliance did in this space. We are the state affiliate supporting the 73 school-based health centers throughout Colorado. We have been doing this work since 1996, and we really looked at this work as an opportunity to reach out to the network and see what they were already doing and build on that and bring partners in. So it was very insightful when we started to look at the project around where the state had gaps in its care. And so we started by looking at, was this an issue that was important in Colorado? Next slide. We found that there was a lot of need. We ranked 44th in the country for SNAP enrollments and 48th for WIC out of those that were eligible in 2018. 2018 sounds like a while ago, and as we started to look at the data, there's always a lag time in collected data and publication of data, so there wasn't a lot more recent. What we do know is that the pandemic exacerbated concerns that were already there and stressed systems that were already not meeting the need. So we saw this as an opportunity for school-based health centers to really step up to this need and to formalize work that we suspected they were already doing. Next slide. So that led us to asking for who wanted to be involved in this work. And we put a general ask out to all of the school-based health centers. I will say that one of the lessons that I'll kind of speak to is that we didn't get a lot of interest initially. So we did some more targeted outreach, really looking at communities that came up in the data around especially high free and reduced lunch rates, low SNAP and WIC enrollment rates, and just high need. So the other thing that we really tried to do when we outreached to sites, and I think that we will emphasize even more moving forward, is that this project was not about reinventing the wheel. This project really looked at saying, what are you doing and how can we make this a smoother, more formal, more routine process in your clinics, and whenever possible, work with the existing data you have. And so that's how we framed it, rolling it out, and we ended up with 10 school-based health centers in the state. You can see on this map, so Colorado is a very large state. We have some rural pockets and some urban pockets, and we were able to get a really good representation of those around the state. Of note, we only had one federally qualified health center participate in the project, and so we're hoping to bring some more different operating organization types into future work. Next slide. So as we structured the program, we wanted to make sure, like Ohio did, that we were really capturing data to show what was happening. I think that is the piece that we just didn't have to start with, which is what was happening to begin with. Who was doing this? How many youth were they reaching? What was the need? And so we created an evaluation plan with the support of School-Based Health Alliance, and that guided the quarterly reports that we set up for the 10 school-based health centers in our project to complete. We had them do that on a quarterly basis. I think that there were some pros and cons to setting up quarterly versus monthly. We only asked for folks to look at it on a quarterly basis, which meant when they did look at it, they had a lot more to kind of go back and look through. And it also gave them fewer needs for when they had to submit that report. So I think in some ways it helped, and in other ways it made it more difficult. I think we'll probably stick to a quarterly basis. It seemed to be a good cadence, especially once we got through the first one. And I'll speak more to what the data showed later. The other thing that we did for data collection was doing surveys following each of our quarterly learning network sessions to gauge the knowledge of the attendees pre and post on that specific topic, and as far as food security work in general. So what we learned from that data, next slide, is that our school-based health centers were able to reach a lot of youth. So we know that there were 2,270 youth screened, and then 20% of those screened was the average amount of positive screenings. The actual data on this got a little bit trickier, speaking to some of the same things that Ohio ran into that Rachel mentioned. The unduplicated versus duplicated patient numbers were sometimes hard to tease out, and we really left it up to the school-based health centers to decide the frequency and the visit types at which they gave these screenings. And so for some school-based health centers, they had more touch points, more screenings than others. And so this average is based on unduplicated screening numbers. The other challenge that we ran into, especially the first half of the project, is that it was surprisingly difficult for school-based health centers to track screening results. That it was just not easy to say. It was easy to say we gave this many youth screening. It was a lot harder to know if they came up positive or not when they reflected back on that data. And so knowing that we were able to account for 20% of those screens being positive, we also didn't account for some of the results in some of those 2,270 youth screens. So it was likely higher, would be my guess, just because we didn't have data for some of them. And the other thing that we asked school-based health centers to track in their reports was the number of referrals to SNAP, WIC, and additional resources. We did ask partway through the project for them to start collecting data on whether youth were or were not already enrolled in SNAP and WIC. And that relates back to that 20% of positive screenings, which seemed a little bit low given the population of youth served and the need that we saw originally in this state. And what we started to see with that data, however, it was not very consistent, and it started partway through the project, so we don't have a good baseline. It seems like there are a lot of youth who are already enrolled, and that the youth that are finding their way to the school-based health centers are fairly wrapped around. So that's something I think that was a lesson learned for us. It's probably really important to keep tabs on alongside the data that we're collecting with food screening is, are these folks already getting resources? So next slide. A few other touch points that our data really emphasize is that approximately 1/3 of the patients that were seen at the clinics were screened. This number did increase over the course of the project. So for one clinic, they were doing this work sort of, kind of, and then this project came in and they went from 4% to 40% of students at the school-based health centers being screened. And so I think that's another area that we'd like to capture better is as you formalize your process, what changes as far as your reach. The other thing I mentioned, it really did take time to figure out how to track those screenings. Most of our school-based health centers use the Hunger Vital Signs screening. A few of them opted to use a more comprehensive social determinants of health screening that had food security within it. And how the Hunger Vital Signs or the social determinants of health screening was delivered was part of the challenge. So the school-based health centers all also screen for a variety of other mental health and social needs screeners. This tool seemed to fall outside of those, which meant the results also fell outside of those. And so pulling what meant positive was definitely part of the learning curve. And like I said, we got that data from the majority of sites about partway through. There was one clinic who was not able to pull that despite their efforts through the entire project. So that definitely skews what we were able to show as far as the number of youth who had that need that were screened. The other thing that was really challenging was tracking if a youth who was referred to WIC or SNAP was then enrolled in WIC or SNAP. We learned from our efforts to talk with state partners that the Colorado SNAP program was undergoing a lot of changes. It had been determined as needing to be put on a performance plan by federal standards. So there's a lot of work to be done at the state level and then at the community levels to, I think, help close that loop. So for the purpose of data, that metric wasn't really doable. However, tracking if those referrals were made was, and I do think if we had asked about it, everybody had a system with a tickler, either in a separate spreadsheet or within their EHR for their staff to follow up. Now, whether that staff was successful in learning about that connection was a whole other issue. So those were the pieces where we had success and challenges once it got to the referral stage. And then, as I mentioned, many school-based health center users were already enrolled in a food assistance program. However, what we did learn is that that did not always mean that their needs were being met, and that there wasn't more that could be done in the space of food resourcing. Next slide. So the other level of work that Youth Healthcare Alliance did was to organize quarterly network meetings with the school-based health centers that were participating in this work. And we sent out an initial survey to those school-based health centers, as well as to folks that we knew were doing work to address food security statewide. And we tried to pair interest of the school-based health centers with what was being done to select topics for those 4 quarterly meetings. We had Food Bank of the Rockies, Kroger Health, Hunger Free Colorado, and the HEAL unit at the Colorado Department of Public Health present at various Learning Network meetings. We also partnered directly with CDPHE's School-Based Health Center program. They distribute the grant funding to the school-based health centers around the state that receive state funding. And within that program, they have a suite of tools that are available for all of their grantees for screening purposes. And so we work directly with them to bring a food security screening into that suite so that any grantee in their program, whether they were working with us in this project or not, had access to that tool. And we're hoping that when they do their next iteration of program standards, which will be in 4 years, that they include screening for food security as one of their program standards. So we really tried to work directly with the state level partners who then have direct access to the school-based health centers, as well as connecting school-based health centers with information and resources to some of these other food programs in the state. And I think one other thing that I wanted to mention around that is that as we did the learning networks, we then followed up with resources, and all of these partners became more of a regular communication with Youth Healthcare Alliance. So outside of this project, we make weekly posts to our entire school-based health center network, and we would get information from Hunger Free Colorado or the HEAL unit to say, hey, this is happening, let everybody know, and then we could share that. And so that was the way that this work started to grow within this, this year of the project. Next slide. So the way that this all rolled out kind of had 2 levels. At the school-based health clinic level, their focus across all 10 sites was to have routine screening processes with standard follow-up for those screening processes to meet food needs. They did this in different ways. Everybody has a unique community with various resources. If you are in the Denver metro area, you are going to have a very different population need than if you are on the western slope of Colorado and have very different population, and you have very different resources to work with. So we tried to make sure that the school-based health centers were also connected directly to their community level efforts to support what they were doing. And they then took those relationships and really strengthened what was happening on the ground there. At the Youth Healthcare Alliance side, we did this through monthly check-ins with the school-based health centers to make sure that whatever we were addressing universally was getting translated into that community level need. And we did that through resource distribution to our entire network, as well as some specific subsets for this project, and then the learning network sessions that we facilitated. Next. And so I think this was covered really well by both the School-Based Health Alliance in Colorado. There is a wealth of opportunity for youth and family involvement in this work, and I think that it strengthens it at every level when youth voice is at the table. So we also found that really challenging. Youth Healthcare Alliance is 2 steps removed from the students using school-based health centers. And so that on its own makes it a little challenging. We are in our 2nd year of having a youth advisory board. So last year was their very first year. And their year 1 coincided with our year 1. And that means that we needed to really figure out how to include them moving forward. And then at the site level, I think it's a little bit more tangible because the students are there. And the one area I want to highlight is one of the school-based health centers that had a food pantry on site put a clipboard by the food pantry. So youth could put down what they wanted that mattered to them. And this, one of the neatest representations I thought was youth asked to have a birthday cake mix with frosting and sprinkles so that they could celebrate occasions in their families. The other thing we asked for was spices, so they could make the food taste better when they, and more catered to what their cultural needs were. And I know we're getting short on time, so just a few other highlights of takeaways of what happened at the state level. They really just formalized what they were doing, or sorry, at the school-based health center level. They were able to say, here's how it's been looking, and let's actually write a workflow for it. Let's dedicate staff to this. Let's have a set screening tool that we use. And then the other things they really worked to do was use motivational interviewing and have a really culturally aware perspective of how they presented that to families, which supported more success in doing this work. I think I've covered what we did pretty well at the state level, so I think we can go ahead and really go to the takeaways, which is school-based health centers are well positioned to do this. They're already doing it. Food is personal and it's cultural, and that needs to be considered when doing the work. Billing for food security is a challenge, and I'm looking at the next iteration of the Accountable Care Collaborative in Colorado, billing for community health workers, and C-code options in our state to get there. And also that a lot of attention is being given to the state, and it's been in its infancy, but we're at the table as those conversations continue. That was a lot. And looking ahead, we're looking to bring more folks into this work and expand on what we've learned from this project to make it a smooth fit into what's already happening. And we'll stop there.
If you each want to maybe talk for a minute or so on what school-based health centers need to do if they are interested in joining your efforts in this work, that would be great.
So for Colorado, we are going to have communication out to the entire network that goes out the very first week of December once we're back from Thanksgiving school breaks. And we'll be asking for interest of folks who would like to pilot. We are creating a workflow to hand to you. And then you can customize it and tweak it for your clinics. And so we'll be sending out detailed information on if you would like to pilot that and the data that we'll be asking for from anyone who chooses to pilot that. So that we will be, be aware. It'll be in our base camp. It'll be a direct email to all of our primary contacts. And if you're interested right now and you know it, you can just send me an email. I'll drop my email in the chat. And we're hoping to launch that group in January.
In Ohio, we're doing some similar things. So we'll be doing outreach in a few different ways. One is our census, which is currently out in the field. So if we have any school-based health center partners on the call, that census might be in your inbox, or you can email me. So we'll be reaching out through that. We'll be having a panel of some of our SVHC food access grantees at our annual conference in January. And they'll be sharing their experience. Oh, thanks, Reem. And then just similar to Colorado, we're hoping to continue to collect data on impact from our current partners and any new partners that are interested, and we'll be developing a few resources to help guide that work as well. So feel free to email me if we have any partners on the call interested.
Thank you to Rachel and Rebecca and Reem for sharing all of your lessons over the last year. I did want to just reference the toolkit again. Please feel free to use any of the resources here and know that we are continuing to add to it. There's actually some newly updated case studies from the work that's been done in Colorado and Ohio. And we'll be continuing to add to it in the coming months as well. And I think that is it, unless there's any questions in our last couple of minutes. Abby, I didn't know if you had anything else.
Nope, I think we just have a couple announcements at the end. So our annual conference is held annually at the end of June in Washington, D.C. And we recently extended the deadline for abstracts. So if anybody is interested in submitting an abstract, please head on over to our website. We would love to have you. The next slide just gives you those dates. So this year it will be June 29th through July 1st. And then I believe the last slide is just connecting with us on our socials. So feel free to ask any last minute questions. Otherwise, we really appreciate you being here. And thank you again.